Okie dokie. I think we'll crack on. So, hello everyone. My name's Rich. I'm one of the co-founders of Bite Medicine. Thank you so much for joining us on this Wednesday evening for our SBA series. We hope to do more of these. We'll be publishing these on YouTube, on the platform for free. We're really keen to see whether or not this is a format that works and people are interested in. So before I jump straight into the SBAs on the platform, I wanted to kind of go through what the session is going to be about and a little bit about exam technique. So the plan for the session, really quickly, we're going to chat about how you should approach answering SBAs, not just in the exam, but in as well all of the questions that you will do as part of your revision, and trying to squeeze every little bit of usefulness out of that process of doing. So we're going to go through some renal SBAs. If we have time, I want to showcase our multi-step SBAs as well. This is something we think is quite unique to Bite Medicine. Essentially, it's a single vignette followed by multiple sequential questions that cover that topic, and they kind of take you through the patient journey. We think it's a much better learning process, and the SBAs can be used as more of a revision at the end. So just kicking off with how to go about tackling SBAs then. So when you're revising them, I'm all too familiar with doing this. I'm sure everyone watching has done the same. It's very easy to just sort of click spam through as many as you can. You can come away after an hour's revision and say, you know what, I just answered 45 questions. Great. The issue with that is the process of doing the questions starts to become less useful. So what I would recommend is, as you're going through a question, when you hit one that you don't know, don't just click an answer to get the reveal, to get that explanation. Have a think to yourself, right, if I was in the exam right now, I've got this level of uncertainty, how am I going to deal with it? Because if you do that, you're going to start to build up techniques that allow you to overcome uncertainty. So you'll start to question, right, what have I missed? Have I gone back through the case? Have I looked at the observations? Have I looked for allergies? Simple things. Obviously, if you don't know, you don't know. And particularly, there are some SBAs that are often just, know it or you don't. That's usually statistics or very specific complications or side effects of drugs. But for ones where it's a little bit of clinical sort of reasoning, I would actually get used to that uncertainty and trying to build up your skills. The other thing you can do when you're revising is, let's say you get a question and it's a barn door diagnosis of multiple myeloma. So they've got hypercalcemia, renal function deterioration, they've got back pain, sort of elderly gentleman, it fits. And you go, yeah, I can see multiple myeloma, I know that's the answer. That's great. But just ask yourself, well, do I know that topic really, really well? Like, what if they'd asked me what the complications of myeloma, or how do I manage it, or what are the risk factors of it? And before you move on, just say to yourself, right, I don't know that, so shall I just quickly go through and just hit the big summary, the big headlines of what are the features, how do we diagnose it with investigations, how do we manage it, what are the complications? And if you do that, you will actually find that 60 minutes where you could have gone through 45 questions, you might get only through 20 or 30, but that revision, that learning is going to be a lot richer. And the final part of the revision process is saying to yourself, do I actually understand this topic? And I'm so guilty of this myself, and I'm sure some of you are as well, where you answer a question through pattern recognition alone. And were you faced with it in real practice, you would never get it in a million years. But because you've become really accustomed to spot a certain way something is phrased, you can just pattern recognize it. But examiners are aware of this, and they'll often do a two-step question. So they'll go, yeah, great, I'm happy that you can recognize that X equals Y, but I want you to go a little bit further and tell me the complication of Y, or a risk factor for Y, or how to manage Y. So ask yourself, do I actually understand this topic, or am I just recognizing that X equals Y every time? So moving on to the exam then, and I will try my best to showcase some of these examples of these techniques tonight. One great thing you can do is the cover test, and most of you will have heard of this. If you haven't, I would firmly recommend doing some practice with it. And this is essentially where, with your written paper in front of you, every SBA, you start anew, and you put your hand over the options. Okay, by all means, read the question. And I actually often think reading the question before the vignette is a very helpful thing to do. But block out those options. So cover them up, read the vignette, and just as you're going through, think, do I know what this diagnosis is? Have I nailed it already? There is nothing more satisfying than revealing your hand and going, my option is in there. It's a much better way of doing things, okay? It will get you engaged a lot more, and it will stop you being sort of persuaded by biases and red herrings that have been introduced into the options. So really practice the cover test in your revision, apply it in the exam. The exam's a bit of a marathon, okay? I went to a med school where we had to do, I think, it was either 100 or 150 SBAs in quite a tight time. You need to get practice at resetting your brain continuously to change from topic to topic to topic as quickly as you can. And actually doing this process of the cover test each time and just kind of in a robotic fashion, covering up, allows your brain to reset. I've moved on from the previous question. I'm on to the next. Another thing to just say is your observations. So if you get a highlighter or a pencil, every time they give you observations in the exam, just go through them. I can't tell you how many questions I've got wrong because I've missed a low-grade fever, or I've missed a tachycardia or hypotension. So it's very easy because they're often just in one little line before the question. Just make a conscious effort of looking through the observations. I say this, we're doing these SBAs blind tonight together, so there's a high possibility that I will, make these errors. But the whole point is to show you that anyone is infallible. But if we can try our best, we will end up, getting a higher score. And then the final thing to consider in the exam is, what is the nugget? What is that little bit of knowledge that the examiner's actually testing? And there's a really satisfying moment when you go, I see what you're after here. And the more SBAs you do, the more you'll realize what the nugget is. And I think it's just a case of just practicing. You'll start to think, okay, this is a question about colorectal cancer. It's looking at this kind of, the FIT test. That's what it's honing in on. I know the answer here, or whatever. So that's really all I wanted to say about tackling SBAs. I have on the platform put these slides up. I've just put a couple of key facts about kidney stuff. I'm not going through it today. There is another video I've given in the past on acute kidney injury that you can look through. But I put it all in here because if you've come to learn kidney, that's really useful for you. But I don't have time to go through that today. I want to go to the SBAs. If you're watching this, you probably have used the platform before. You know what we're about. We've recently, and I mean recently in the last sort of 48 hours, have added a load more questions to the bank, which we're really excited about. If you haven't used it yet, our textbook is now fully editable, so you can essentially use it as your notes. And we're looking to just absolutely flood you with webinars over the next few months on all sorts of different topics. So tell your friends about us. Check out our free resources. If you like what you see, by all means, get a premium account. We think this is a good product. We think we have a nice offering. But first and foremost, why don't we jump into some questions? So I'm hopefully going to be sharing my screen here. So you guys should be able to see this. So we're going to be doing the single best answers first of all. This is the case-based scenarios are those multi-step SBAs that I told you about. So today's session is all about renal. So we're going to set the renal questions up and we'll see how many we can get through. So essentially this is a viewing process for you to kind of see how other people might approach answering an SBA. So a 65-year-old woman presents to the emergency department, decreased urine output, general malaise, past medical history of high blood pressure, type 2 diabetes. On examination, she's dehydrated, blood pressure is elevated. Okay, so straight away, even before I get any further, I'm doing the cover test, I'm not looking at the options. I've seen hypertension and oliguria, okay, which straight away to me, that's 2 out of my 3 features of nephritic syndrome. So I'm already thinking, is there going to be elevated blood? But as I go down, I see, no, there's no blood. So points me slightly away. So haven't got loads of clues here, but it does tell me that the sodium is significantly elevated. Now, when sodium is is high in the urine, what that's essentially telling you is your kidneys haven't reabsorbed it. So in that tubular system, they've not reabsorbed the sodium that they should have. One of the most common reasons for this is acute tubular necrosis. So essentially the tubular cells die. So that's what I'm thinking currently. So question is, which of the following drug classes is most associated with the development of acute tubular necrosis? So this is one of those questions, I think it comes up quite frequently. What they've given you here is a whole host of different antibiotics. There should be an antibiotic that comes to mind when you hear the term nephrotoxicity, okay? And that should be gentamicin. Other examples of that drug class would be amikacin. So then it's a case of just know, well, which drug class is that? And I think in this scenario, I'm going to go aminoglycosides. Just letting you guys know that in the exam, much like you can do on the platform, you can cross things out. So I would fully recommend that. So let's see how we got on with that. Okay, incorrect. Didn't like that. So I told you guys, I'm not going to get all these right. So sulfonamide antibiotics, often referred to as sulfur drugs, associated with the development of acute tubular necrosis. So I guess the learning from this really is that I need to go away and look up my drug causes. I'm not 100% convinced by that. I do think that gentamicin can cause this. Someone's just to ask, just to let you guys know, someone's asked, did you actually need to read the vignette to answer this SBA? The answer is no. And not all SBAs are fantastically written. So by all means, check the question first if you need to, because essentially he's right. Whoever, or he or she, whoever wrote that, you could have just jumped straight away. There is occasionally a risk that you might miss something if you do that. There might be a little sort of allergy or something like that. So let's move on. Let's see if I can up my score. Okay. So the following kidney function results for a group of patients have been returned to the GP for review. Okay, so down the side, we've got patients 1 to 5, and we've been given their eGFR from 3 months ago and from today. So this is probably going to be looking at a CKD. So yeah, CKD is the question. To diagnose CKD, you have to have 2 eGFR results from 3 or more months apart. Because if you just go off a single eGFR result, you don't know if that's an acute drop in function or chronic kidney disease. So that's an important thing to know. And they've also given some additional results. So if we jump to the question, like my friend in the questions has asked, should we do that? I think we should. So which of the following patients can be diagnosed with CKD given the information available? So if we just work through them. So if someone's got an eGFR more than 90 on 2 separate occasions and no additional indication that they have structural kidney disease, and we'll get back to that, then we can say that they do not have CKD. Next person, well, they were 87 3 months ago and they've dropped to 44. So anything below 60, we start to worry about CKD. But the fact that they've dropped within that time period says to me this is more like an acute kidney injury. And the fact that they're nitrite positive, potentially they have either urinary tract infection, pyelonephritis, something that's caused them to maybe be dehydrated or just directly caused a acute kidney injury. So it can't be that. Next one. So we've got someone that's teetering around this 60 mark, less than 57 3 months ago, but it's just gone up above 60 here. And they have glucose on their urine dip. However, glycosuria is not by definition an example of structural kidney disease. So I don't particularly like that one as CKD. This one is very similar to patient 1. However, we've got some additional information here. We've got an albumin-creatinine ratio of 4. And this is one of those know it or you don't scenarios. But if it's more than 3, that is a sign of leakiness. It's a sign that your albumin is passing through the glomerulus into the urine. And so in this scenario, that would be an indication of chronic kidney disease. So if someone's got an eGFR of 90 or more, they would score CKD 1. Okay, so the highest or the best possible score you could have. So I'm leaning towards 4. And the reason I don't like 5, well, 65 and 55, so they're not both below 60, and that ACR cutoff of 3. So we're going to go with patient 4. Let's hope for being correct this time. Excellent. There we go. So NICE defines CKD as abnormalities of kidney function or structure present for more than 3 months with implications for health. So here we go. Given the persistent ACR more than 3, patient 4 would be diagnosed with CKD stage 1. For those who haven't used the platform regularly, you can look and see why other things aren't correct for each one. But in the interest of time, we'll move on. Let's see if I can up my score. So, 37-year-old man has been receiving hemodialysis via an AV fistula for the last 2 years. And if we look at the question, it's saying which of the following is true of tacrolimus use. So we're thinking tacrolimus is an immunosuppressant. We're thinking this is probably going to be a renal transplant question. So he has a background of adult polycystic kidney disease causing end-stage renal disease. He was on the transplant list and has been invited for the allograft. So that's the transplant. He recovers well, and after induction of his immunosuppression, he's commenced on a maintenance protocol that includes tacrolimus, mycophenolate, and prednisolone. So that's a pretty standard sort of grouping. Now, this is it's one of those ones you either know it or don't. So is tacrolimus excreted by the kidneys? Well, no, it's metabolized in the liver. I wouldn't recommend knowing how everything is metabolized, but in this instance, I think it's worthwhile. Can it cause visible tremors? Absolutely. Okay, you might hear it called the tac tremor. Okay, so for those who are still doing OSCEs or PACEs, when you're doing the abdominal exam and you're examining for the hepatic flap, also just look for a much finer tremor, which may indicate salbutamol use, or if they've got a renal transplant or a liver transplant, tacrolimus use. So I'm leaning towards this one. Tacrolimus is a calcineurin inhibitor. For gum hypertrophy, for those who are nodding, this is a cyclosporin side effect. So cyclosporin can also be used in the immunosuppressant regime. So this is one of those ones where you go, aha, I see what you're doing. And finally, it can cause hypoglycemia. Well, no, actually, it's more of it drives glucose intolerance. So essentially, it causes hyperglycemia. So we're going to go for visible tremors, and let's take a look. Excellent. I got to tell you guys, it's far more stressful when you're trying to explain these and then hoping that your explanation rings true. But I hope this is useful. If anyone's got any more questions, by all means, drop them in the chat. So we'll move on. So, 62-year-old woman presents to her GP for regular blood monitoring. She regularly takes amlodipine. This is another point of contention here, guys. Every time you're going through SBAs, just test yourself on everything. So when you get shown a drug, you may as well say, do I know what that drug does? So in this case, she regularly takes amlodipine, which is a dihydropyridine calcium channel blocker, and ramipril, which is an ACE inhibitor. She's recently been prescribed naproxen, which is an NSAID for arthritic pain. The GP gets an alert with her blood results stating that she has stage 2 acute kidney injury with electrolyte disturbance. Now, again, in the real exam, you might not have time to do all that, and you'll also probably realize that it has not a lot to do with the question. But getting quick and fast at just picking apart SBAs will help you in the exam if, for whatever reason, there is a little hidden thing there. In this case, it's a lot simpler. So question is essentially, what's the electrolyte disturbance? Well, I think it's fairly common knowledge that patients with failing kidneys end up with hyperkalemia, so high potassium. There's a number of different reasons why this happens. It's a little bit to do with the fact you gain a sort of acidemic state, so you do this kind of proton for potassium exchange. You also not the kidney itself isn't handling potassium correctly, so it starts to build up in the kidneys. So that's the main reason why. It's one of the criteria for dialysis. So refractory hyperkalemia is a reason why you would end up having dialysis. So again, trying to bring in different things to confirm your thought in the heat of the exam can really help. Excellent. So we'll just go through this one. So reduced urine output leads to the accumulation of certain electrolytes, including potassium. Hyperkalemia is particularly important to investigate and treat, given the fact it can cause arrhythmias and arrest. The AKI here is likely being precipitated by her nephrotoxic medications, ramipril and naproxen. Excellent. Right, so a 63-year-old woman with chronic high blood pressure presents to her GP with lethargy and pruritus, that's itching. She's been poorly compliant with her antihypertensives. Her most recent blood pressure readings reveal that her systolic blood pressure is consistently more than 160, and blood tests demonstrate an eGFR of 32. It was 48 6 months ago. So before we jump into the question, that's a pretty notable deterioration. So it's gone down by 16, but it's also gone down by more than 25%, which is, I believe, an indication to get in touch with nephrology if it's consistently dropped by more than 25%. So that's just a by-the-by fact to kind of bear in mind. And again, this should be the kind of stuff that when you're preparing and answering SBAs for practice, think to yourself, do I know the NICE criteria for referring a patient to nephrology? Because not every patient with CKD needs to be seen by a nephrologist. So little things like that should just then say, right, I'm going to pause my SBA practice for a second, do a quick Google, update my notes, back in we go. And actually that little break probably is going to be really helpful for your attention. Anyway, the question is, which of the following complications is patient most likely to die from? This should be a pretty barn-door one for you guys. These are all complications of end-stage renal disease. The malignancy here, I think, particularly is alluding to the fact that people with end-stage renal disease often get transplants, and those on immunosuppression have an increased risk of malignancy. But I think actually just by definition, they are, even without a transplant, they're at increased risk. But the answer here is cardiovascular disease. Wonderful. So yeah, if you want to read up about other things, I'm hoping we're going to get a CKD MBD question today, so I won't spend loads of time on it. But it's rare for people to die from that alone. Okay, guys, clawing it back after that abysmal start, I'm still unhappy about, but it's all right. So, 17-year-old boy presents to the GP with his carer. It was noticed that the water in the toilet pan was pink tinged after he had used it. So they're essentially saying here hematuria without saying it. You do need to keep in the back of your mind, has he eaten a load of beetroots or is he on some strange drug concoction? But the likely suggestion is that this is hematuria. He's unable to confirm this due to significant learning difficulties and a past medical history of retinitis pigmentosa. So it's not a condition in itself, it is a syndrome. So it's seen with lots of different conditions. And it's essentially where you get this sort of black spiculated pigmentation in the peripheries of your retina that causes tunnel vision and night blindness. So you lose the peripheral vision. So it's often associated with genetic conditions. That's something you can kind of take home for free. So I would definitely hang on to that and think, right, what are we dealing with it? The question is asking for a diagnosis. So you definitely need to be thinking, right, do I know any genetic conditions that cause nephritis? He's hypertensive. Great, that fits with nephritis. And 4+ blood, yeah, also fits with nephritis. So even before you get to the question, you need to think, right, what conditions do I know that cause like a nephritic picture? And there's loads, okay? But with significant learning difficulties, visual disturbance in a young male there should really only be one answer that jumps to mind, and that is Alport syndrome. And you get that lovely moment when you see it. Okay. So before I click it, I think it's really good practice, especially when you're confident you've got the diagnosis and you see it after doing the cover test, just going back through and thinking, right, could any of these fit? There's no mention of recent infection. And I think at undergrad MBBS level, you would expect a mention of infection, which basically rules out post-streptococcal GN and IgA nephropathy. Anti-GBM antibody disease, that's Goodpasture syndrome. It theoretically could be. You'd also be expecting sort of history of hemoptysis as well, because they get alveolar hemorrhage. That's not mentioned. GPA is a vasculitis, could cause these symptoms, but wouldn't explain these in isolation. So it's going for Alport syndrome, which is an X-linked condition that mainly affects boys. And essentially, you get frank hematuria, sensory neural hearing loss, and ophthalmological problems. So you get sort of lenticonus of the cornea, you get retinitis pigmentosa. I remember distinctly, so one of the ways I used to make my medical notes was used to do drawings of patients, just really simple, not an artist, but like it was either a man or a woman, and then just some facts coming off. So you imagine like a Cushingoid habitus and all the things. And I remember doing one for Alport's, and it was a young boy with red urination, and I drew X's over his eyes and big ears with X's over his ears. And that to me was enough, and I still carry it with me now, to remember eyes, ears, blood in the urine, that's Alport syndrome. So just to say, guys, if you are using the platform, you can then go and read up on Alport syndrome in the textbook. So there's more that you can learn about. But I think for the purposes of today, we're just going to stick with the questions. So we've got a picture. So 21-year-old woman is brought to hospital by ambulance with confusion and fevers. Patient's barely rousable, unable to give a history. She's accompanied by her flatmate who reports that she's been feeling unwell for several days and had stopped her kidney treatments for an unknown reason. Very vague. When asked for further information about the patient's medical background, the flatmate is able to show you a picture from their social media that shows her during one of her kidney treatments. So let's see if we can get this up big. So this is peritoneal dialysis, okay? So essentially you hang a big bag of dialysate, which is the kind of the fluid that then comes down this tube into the peritoneum, where the peritoneum acts as a kind of membrane for dialysis, and it clears the blood out. That peritoneal fluid that then contains all the nastiness, all the kind of things that needs to be excreted, is then pulled out of this second tube, which is currently clipped, but will be unclipped, and then into a bag for drainage. So that's peritoneal dialysis. I think this is not the automated type, which is the one you do overnight. This is the sort of continuous ambulatory version, so CAPD. Great. And I said we need to look at the observations. I think that's really important. So she's agitated, diffusely tender abdomen. That's really important there. And she's confused. She's tachycardic. Don't like that blood pressure. She's tachypneic. SATs are okay. And she's feverish. So until proven otherwise, this is an infection, okay? And the question is, what's the likely cause? So you've got a bunch of different things. Ultimately, whilst Occam's razor is a thing and, the common things are common, I think in a case where you've been given a patient with peritoneal dialysis, you've got to punt for something that's wrong with the peritoneum, which gives you these two here. So bacterial peritonitis or sclerosing peritonitis. And it's going to kind of come down to, a bit of luck, or if you've actually happened to read about this, but sclerosing peritonitis is a non-infectious process. It is very rare, but it is a fatal condition where the peritoneum essentially just scars up. Bacterial peritonitis, I don't actually think it's fair to call this spontaneous. And I think I'm going to go away and rewrite this question because spontaneous implies we don't know what caused it. Well, actually, this patient's continuously, they've got a line that connects to their peritoneum that's exposed to the outside world. That's a risk factor for infection. So I'm thinking this is bacterial peritonitis, which fits with the case. Excellent. That's great. So peritoneal dialysis predisposes patients to bacterial contamination of the cavity and subsequent bacterial peritonitis. Likely reason the patient would have stopped her kidney treatment was due to a change in consistency of her fluid dialysate from colourless to cloudy, suggesting the onset of the peritonitis. So that's a bit of a reach for you to get at. However, it's a really important fact because this could just as easily have been a patient we didn't know was on peritoneal dialysis who would come in with diffusely swollen, tender abdomen, where we had, the doctor in the scenario pulls off a bit of fluid during an ascitic tap, and the fluid is cloudy, it's not clear. And that is a textbook example of peritonitis. Wonderful. So let's keep moving. Oh dear, another picture, and we've got some histology. Oh dear. So 44-year-old woman presents to ED with progressive swelling of both of her legs for the last 2 months. So we're thinking edema. She has no prior past medical history, but admits to regularly using intravenous heroin. Urinalysis reveals protein plus, and she's admitted to the renal ward for further assessment, and a renal biopsy is sent. So I think often SBAs are a little bit contrived. I think it's important to remember that a patient wouldn't necessarily get a renal biopsy immediately, but if there was a strong suggestion that biopsy would help, then maybe it would be expedited. So they want us to look at this. Now, I actually think you can get this diagnosis from a couple of the clues in the history. However, there is something important within this image, and that is the sort of increased sort of parenchyma that you can see within this glomerulus in just one segment of the glomerulus. Okay, there's your clue. So what's the most likely diagnosis? Well, we've got some scenarios here, and essentially we need to pick what is the cause of this patient's nephrotic syndrome. And whilst all of these can cause nephrotic syndrome, some of them are they could cause nephrotic nephritic, like MPGN. You could, if you were a betting person, go for, well, what's the most common cause of adult nephrotic syndrome from this list. And that would leave you with membranous glomerulonephritis if they're a Caucasian patient, and focal segmental glomerulosclerosis if they are Hispanic or Afro-Caribbean. The additional clue, if we ignore the biopsy, is that they are a heroin user. Now, use of heroin is a strong risk factor for focal segmental glomerulosclerosis. So another point for FSGS. The final point does come from the histology slide. It's the fact that there is a segmental scarring to that glomerulus. The word focal suggests that actually if you made this histology slide bigger and there were more glomeruli to look through, the focal suggests that only some of the glomeruli are affected. So I'm going to go with FSGS and pray that that explanation was enough to be right. Excellent, look at that. So patient has clinical features of nephrotic syndrome requiring a renal biopsy. The past stain on light microscopy shows sclerosis in segments of the glomeruli. Together with the risk factor of heroin use, this makes FSGS the most likely diagnosis. Wonderful. Oh, it's our friend again. Look, they're having peritoneal dialysis. So a nephrologist has invited you to her clinic in the outpatients unit as part of your renal placement. The first patient you review has been at the unit for 20 minutes already, having started a new treatment today. You approach her with the consultant, and she appears as in the image. Which of the following treatments is this patient receiving? Look at that, guys. We've answered it already in the previous question. So it's not hemodialysis because they would either have a fistula or some sort of line, either in their neck or their groin. Um, we don't think this is plasmapheresis because, again, that would involve taking blood out of their body to pass through an exchanger to remove antibodies. So the top one is large volume intravenous hypertonic saline, essentially just giving 3% sodium chloride through a drip. Well, it's going into a tummy, not a cannula. So that doesn't fit. We're left with 2 peritoneal dialysis. I said earlier, so the automated one, that's something that's done overnight. I believe the machine's at home with the patient. So as a result, we think this is going to be continuous ambulatory PD. Woof, look at that. So, yeah, this patient is having CAPD, evidenced by 1, a large fluid bag above the level of the abdomen, 2, a line from the bag connected to a peritoneal catheter, 3, a second clamped line exiting the peritoneal catheter, draining to a bag on the floor. So it's normally performed at home. It's 4 times 30-minute sessions per day. I think this is really useful. I think peritoneal dialysis is something that's not that well taught. So, being able to look up what it is really useful. So, automated PD involves the use of a machine to cycle fluid through the peritoneum 3 to 5 times during the night whilst the patient sleeps. So in this case, the patient sat out with no machine, which makes CAPD more likely. Wonderful. Okie dokie, so we've got some bloods. So a 54-year-old man is recalled for further blood tests by his GP. A routine screen 3 months prior identified some abnormalities. Jump into the question, given the light diagnosis, what's the most common cause worldwide? Now, given that we know this is a kidney theme, straight away I'm jumping to this is probably a CKD case and they want to know what's the most common cause. And you can confirm that very easily by looking at the EGFR. So it's below the level of 60 3 months ago and today, which automatically puts this patient at CKD 3, specifically 3A. Irrespective of any structural kidney disease. So the structural stuff, that's the kind of blood in the urine or the ACR more than 3, and I think polycystic as well. Those features only really apply to patients with an EGFR greater than 60, so between 60 and 90, plus a structural issue, that's CKD 2, above 90, and a structural issue, that's CKD 1. But here we don't you need the extra stuff we've got that's a CKD 3. So we want what's the most common cause worldwide. Oh, now I know confidently the 2 most common causes are hypertension and diabetes, followed by the glomerulonephritidis as a collective, and also the adult polycystic kidney disease. So I'm thinking between hypertension and diabetes. In all honesty, I'm not 100% with this one. I'm going to go with diabetes. Diabetic nephropathy is pretty rampant and all over the world. Diabetes is fairly poorly controlled. So let's have a look. Excellent. Look at that. Chuffed. So we've talked about how this is diagnosis of CKD. So persistent hyperglycemia causes glycosylation of proteins on the efferent arteriolar surface, resulting in hyaline arterial sclerosis. If you're preparing your SBAs with, 2 weeks to go before your exams, that's the kind of stuff that you just take the L on and don't worry about, okay? So essentially causes hyperfiltration in the glomerulus, mesangial cell expansion, and over time becomes leaky. Diabetic nephropathy in a nutshell. Okay, 73-year-old woman admitted to the transplant ward following a successful kidney transplant graft. She has a background of SLE, which caused diffuse proliferative nephritis and end-stage renal disease. So that's how she got her transplant, through SLE-related kidney disease. She's reviewed by the operating surgeon, commenced on an induction regimen of tacrolimus, remember, hepatically excreted tremor, mycophenolate mofetil, and basiliximab. Which of the following describes the correct mechanism of action of basiliximab? Okay, right. Not 100% sure about this one, guys. So I'm going to try and work through and see if we can get. So anti-CTLA-4, that is ipilimumab. So that is a medication that's used in cancer. It's an immunotherapy. So I'm not going with that. TNF alpha antibodies, classically, these are treated for things like, ankylosing spondylitis, different rheumatological conditions. It's also occasionally used for inflammatory bowel disease, I believe. I'm not liking that one either. Anti-CD20, that one I think should ring bells for people. That's rituximab, but it could also be basiliximab. I don't know. IL-2 receptors I know are important with transplants. That's where I'm putting my money. Not sure what an anti-IL-1. I think that's just interleukin-1, which I think is also used in some rheumatological conditions. So I'm thinking interleukin-2, could be CD20. Let's go down the middle and let's see if that powers of deduction got us right. Wicked. Okay, it did. Wonderful. So there you go. That's a little nugget that you can take away. So anti-TNF used to manage autoimmune conditions like rheumatoid, angst-spond, IBD. Excellent. Anti-CD20 is our rituximab used for non-Hodgkin's lymphoma. So we've worked that out through powers of deduction. Anti-CTLA-4, ipilimumab, which is our immunotherapy for cancer. And these anti-IL-1s, canakinumab, used for autoinflammatory conditions. I mean, yeah, sure. I think a lot of you will probably be sighing and thinking, oh God, can't learn all those. Maybe take that as a sign, if you do have that moment when you're doing questions, if there's a consistent thing that comes up that makes you sigh, is it worth just pausing your questions, getting a piece of paper for 10 minutes, making a helpful table, and just trying to commit it to memory, or trying to think up some way that even if you don't want to commit it to memory, you could kind of figure things through nearer to the exam. Because that 10 minutes might be more worthwhile than the 2 extra questions or 3 extra questions you did in that time. So someone had written on the comments for that last one, I opt out of this information. I feel you, friend. So a 68-year-old man presents to his GP for review after having some blood tests for a Wellman check. Shows he has a mild stage 1 AKI. On questioning, he denies any infective symptoms. He's not on any new medications. He recalls that he's had some trouble voiding urine recently, describing hesitancy and urinary urgency. Urinalysis is unremarkable. That's important because if there was blood or sugar, might point you down a different route. Similarly, if they bother to do a urine sodium, that's going to point you towards acute tubular necrosis. And then OBS, again, picking up the OBS, he's hypertensive. Don't forget that. So what's the most appropriate classification for this patient's AKI? Okay, so you'll probably know pre-renal, renal, post-renal. Within renal, then you can divide it into glomerular, interstitial, tubular, and also the intrinsic blood supply. In this instance, the only thing we have to go off is he's been having lower urinary tract symptoms. Therefore, we've got to go with post-renal. Excellent. Nice, easy, slam dunk. Let's move on. Oh, okay, lots to read through here. Right, so this is one of those ones where you can actually save yourself a massive headache. So we said, look at the question. So we're going for a diagnosis. And yes, you can read all of this. You can scan it, you can do whatever. But right at the bottom, the last thing you're given is on urine microscopy, the patient has muddy brown casts. That is a pathognomonic description of a disease. And I think as a result, this patient has to have acute tubular necrosis. It's backed up further by the fact they've got raised urinary sodium, which we talked about earlier. They've got a reduced kidney function, which fits with AKI and acute tubular necrosis. So let's see, is it in our list? Yes, it is. Before we tick, let's look through the other stuff. Nephrotic syndrome, we're not given the not given the protein in the urine, so I'm not punting for that with such little knowledge. CKD, Yes, his EGFR is low, but we've got nothing to go off. There's no prior history of renal disease. Diabetic nephropathy, glucose is negative in the urine. We don't have an HbA1c. Acute glomerulonephritis, there's no blood in the urine. There's no other features to suggest it. So powers of deduction plus pathognomonic, got to be ATN. So 6-year-old man presents with fatigue, general malaise. He's been experiencing these symptoms for the past 3 months and they've progressively worsened. He also reports a decrease in appetite and intermittent muscle cramps. Okay, muscle cramps. Is he on a statin? No, he's got type 2 diabetes. He's on metformin and enalapril. So latest bloods are shown. Oof. I'm going to jump to the question. Okay, they want the diagnosis. pH. Okay, so he's acidemic. Sodium is 129. Hyponatremic. Borderline hyperkalemic. What's that chloride doing? Do we have a chloride? So chloride, upper end of normal. Bicarbonate is low. So if he's low bicarbonate, that might explain his acidemia. His urine pH, oh, is that low or is that, I mean, it's acidic, but is it extremely acidic? We'll go with that being acidic. Cortisol's okay. HbA1c is up, which fits with his diabetes. So what is the question here? I've got a horrible feeling this is going to be one of those renal tubular acidosis questions. Oh, look at that, it is. Right. I used to know this once upon a time. So is there a way we can narrow this down? So diabetic nephropathy. So whilst diabetic nephropathy can cause kidney impairment, we haven't actually been given any kidney function issues on here. So I'm going to get rid of diabetic nephropathy. Addison's disease, by definition, that's primary adrenal insufficiency. I'm binning that off because his cortisol's okay. Which leaves us with our 3 types of renal tubular acidosis. I'm sorry to let you guys down on this one. I don't think I'm going to get this one right. So type 1 renal tubular acidosis is a problem with the distal tubules. I think it's often the more extreme type because in type 2, where it affects the proximal tubule, there's an issue there with transporters and stuff. The tubular fluid has time to get round to the distal, which is still functioning and can fix the problem slightly. So as a result, I'm thinking maybe if this is type 1, given the problems here. However, my brain's starting to wake up now. Low sodium, high potassium. Is that renal tubular acidosis type 4? In the exam, guys, if you get one of these and you really don't know, pick and move on, okay? If you do think you know, by all means, star it and come back or just spend an extra 30 seconds trying to figure it out. What causes low sodium and high potassium? It's hypoaldosteronism. Is that linked to type 4? Let's have a look. Oh, look at that. I'm not taking credit for that, guys. That was not a lot of intelligence went into that. But according to this person, RTA type 4 is easy to distinguish from type 1 and 2. It's the only form of renal tubular acidosis with hyperkalemia. Can be caused by hypoaldosteronism, e.g. Addison's, which can be, so from Addison's or from something secondary like diabetes, or from aldosterone resistance drugs such as enalapril and plerixafor. In this case, it might be the enalapril. Blimey. So RTA type 4, takeaway message is look for hypokalemia. Type 1 and type 2, Uh, Type 1 suggested by hypokalemia, normal anion gap metabolic acidosis, and alkaline urine. In this instance, the acidic urine and hypokalemia rule it out. And proximal, which is our type 2, often presents with a normal anion gap acidosis plus features such as rickets or osteomalacia. There we go. Wow. Yeah, take the L, guys. Let's have a look. A 56-year-old man is reviewed by the GP after some recent follow-up investigations. He has a background of chronic kidney disease stage 3A, secondary to type 2 diabetes. He's otherwise fit and well. He takes metformin 1 gram twice daily, glycoside, ramipril, atorvastatin, and cholecalciferol. So a classic concoction for someone with CKD. His latest eGFR is 44, HbA1c is 52, urinary ACR is 60, pretty high. He's apprehensive about his deteriorating kidney function. Which of the following features, if present, would warrant a referral for specialist assessment of CKD? So this, guys, was something I mentioned much earlier on. This is your nice criteria for referring to a nephrologist with CKD. Now, looking at that question, which of the following features, if present, would warrant a referral for specialist assessment of his CKD? So specific to this patient. I think I mentioned earlier it had to be a sustained decrease in eGFR of 25% more. I therefore don't think that a drop of 10 would meet 25% in a lot of cases. Like in his case, 44 down by 10 is not quite 25% drop. Which leaves us with these things. I don't know the answer here. Something in the back of my head is saying if you are a diabetic or if you've got glycosuria, the threshold is higher. So in view of that, I'm going to go down the middle. But it's something I think I need to brush up on, guys. Ah, fantastic. Okay. So NICE recommends an ACR of more than 30 together with hematuria as a criterion for referral to secondary care. So let's look at these other ones then. An ACR of 70 or more warrants referral in most instances. However, NICE specifically acknowledged that an exception is if the patient's CKD is caused by diabetes and already appropriately treated. Interesting. And therefore, with this one, same goes. So yeah, I can't pretend to be an expert on all things kidney, guys. But I would say this is if you've got the time, look up the criteria on NICE. So what I'm going to do, just to kind of stick to my promises, I'm going to bring the SBA part of the session to a halt now. Just for the last sort of 5 to 10 minutes, just want to showcase the multi-step SBAs for renal. So there's plenty more questions that you could crack on with on your own if you're a premium user. I think some of these are free for all people anyway. Thank you for watching this bit. I'm just going to quickly switch now to our multi-step. I'm just going to do one because, as I said, there are multiple questions linked to each vignette. Let's see if we can do something a little bit spicy. So we're not going to do that one because he's got hearing aids, gross hematuria. That's Alport syndrome. We've already talked about that tonight. Okay, let's do this one. 52-year-old intravenous drug user presents to hospital with shortness of breath, tachycardia, and pleuritic chest pain. An echo is unremarkable. That shouldn't be in capitals. They're diagnosed with a PE and commenced on an oral anticoagulant. So that tends to be the route now as we give apixaban for PE. On the day of discharge, routine examination reveals that the patient has swollen ankles with pitting edema. Okay, is that a side effect of the drug or is that part of their primary issue? Which of the following tests would not be appropriate for investigating these examination findings? So a word of, I guess, caution Negative questions really shouldn't be included in your exams. Sometimes they slip through. They shouldn't really be there. For the purpose of question banks, it can often be quite useful to be able to test lots of facts in a kind of flipped way. But I think they've been removed in most higher education settings now because they're unfair. People can easily miss it. So what wouldn't you want? I mean, in this instance, if we've already diagnosed a PE, you're not going to be doing a D-dimer. That's useless. Whereas if they've got edema, well, what can cause bilateral edema? Heart, liver, kidney. So serum proBNP is your heart, using and urine is your kidney, liver function is your liver. So I'm going with D-dimer. Bingo. Yeah. Likely would be raised anyway. So urine dip reveals protein plus, but is otherwise unremarkable. Serum albumin is 24, so that's low. Urinary ACR, that's very high. We've seen already, guys, that I think you said more than 70, unless they've got diabetes and it's treated, is a criteria for referrals. That's bad. They're very leaky. What's the most accurate likely diagnosis? Right. Accurate. What they're getting at here is they want a diagnosis, not a syndrome. So going to bin off nephritic and nephrotic. Leaves us with three things. Of these three, one classically causes a nephritic syndrome, so hypertension, oliguria, hematuria, which is not seen here, and that's IgA nephropathy. Leaving us with two more, minimal change disease and MPGN. Minimal change disease, a fact you should all know is it is the number one cause of nephrotic syndrome in children. This patient's 52, so we're binning that off, leaving us with MPGN. We're going to ignore the fact that there's a little hint here that the answer was MPGN as well. So let's see. Oh no, it didn't like it. Oh no. So, okay. So it's done a 180 on my reasoning. So numerous causes of nephrotic syndrome. However, without further testing, a diagnosis of a specific cause cannot be made. And as such, the most accurate diagnosis that can be made at this stage is nephrotic syndrome. Fallen on my own sword. Okay, guys, well, there we go. That's something to learn. So nephrotic syndrome, triad of proteinuria, hypoalbuminemia, and edema. The edema is refractory to oral furosemide. Further investigations reveal depleted C3 and C4. He's consented for a kidney biopsy, and the report states subendothelial and mesangial immune deposits resulting in a tram-track appearance and mesangial proliferation. Cool. And it wants to know which one is it. Blimey. Well, my reasoning from earlier and the fact that this is here says it's going to be type 1 or type 2. I have no idea the difference. So in the interest of time and getting on to some of the other questions, let's just see if it's type 1. It is, okay. So it's a rare cause of nephrotic syndrome. However, a unifying characteristic for all types of MPGN is hypocomplementemia and mesangial proliferation, which is seen here. Distinguishing features of type 1 include occasional low C4, tram-track appearance on electron microscopy, and a background of SLE, blood-borne viruses, or lymphoma. I think the hint then is because they're an intravenous drug user, maybe they've had a blood-borne virus. Not easy. That's a tricky one. Blood-borne virus screen is performed, which reveals the patient's hepatitis C virus positive. This is the likely cause of his MPGN. What is the most appropriate management to commence? Ooh. So I guess the question is really asking is, do you start management of their kidney disease? So that would be kind of ACE inhibitor, statin. Or do you treat the hep C? No idea. Absolutely no idea. Well, I've already been schooled by this one, so I'm going to go with a simple answer of ACE inhibitor and statin. Let's see. Oh, no. So this patient has secondary MPGN. It's recommended that the secondary cause is directly managed, as well as the use of immunosuppression therapy in patients with proteinuria in the nephrotic range. As such, this is the most likely correct answer, although an ACE inhibitor would likely be commenced. Oh, come on. You'll find these questions, guys. Any question bank, the ones where you go, ignore. ACE inhibitors are offered for almost all patients with CKD to reduce the rate of disease progression. It's very likely they would be commenced on an ACE inhibitor. Statins are only commenced if the patient's lipid profile indicates the need. This answer does not represent the most appropriate management. Okay, fine. So there we are. We needed to treat the hepatitis C virus. Which of the following is not a recognized complication of nephrotic syndrome? This is a stinker of a case, I must say. Right. So nephrotic syndrome, complications, trying to kick myself back into it now. So you have an increased clotting risk due to antithrombin 3 deficiency. I think you get hypothyroidism because you lose thyroglobulin. You lose your immunoglobulins. It's all because of the leakiness of the glomerulus, so infection susceptibility. So which of these is not? So I'm ditching that one, ditching that one. If you lose albumin, albumin's a carrier of calcium. If you lose your albumin, you should have a raised calcium. So that fits. So that's not. Which of these is not? Oh boy. Well, should we go with hypertension and C? Down to 2. Got to roll the dice. Oh no. Okay. Hypocalcemia is a recognized complication of nephrotic syndrome. The urinary loss of albumin, the main calcium transporter, leads to lower circulating levels of calcium. Okay. Because, all right, fine. So hypertension is a complication, and hyperlipidemia. Hypoalbuminemia leads to a compensatory increase in albumin synthesis in the liver. However, the liver also incidentally increases synthesis of lipids, leading to hyperlipidemia. Okie dokie. God, I'll be glad when this case is over. I've done terribly. So what was the likely cause of this patient's PE? Oh, was it a complication of nephrotic? We did say that you lose antithrombin 3 deficiency. I mean, it could be any of these, really. Let's go with that one. Hey, okay, finally, end on a win. It's given me a green tick. I think if you get less than 50%, you don't get a green tick. So I'm going to call it there because I think that was a humiliating performance. I think it's a very, very difficult topic, renal. I think don't beat yourself up with it too much. Common things are common, and your exams are going to focus on that, but there will always be an occasional stinker in there. And I think renal lends itself quite nicely to that. So yeah, I think it's one of those specialties. You're not going to get hundreds and hundreds of questions on it, but there could be a few, and I think it's good to be prepared. So I think that basically brings me to the end. Thank you guys so much for watching. I hope this was useful, whether you're watching it live or you're watching it back as a recording. If you did find it useful, we'd love to hear from you. You can either Instagram us, you can email me, richard@bitemedicine.com, with suggestions of what you'd like to see next time. We probably will do a session in a few weeks' time, maybe on one of the more common areas or maybe on one of the less common. We'll see. As I say, I go do these blind, so ideally we'll do a session on a topic that I'm fairly familiar with. But I guess the point is to see how someone who doesn't know what the answer is deals with it in a real-time scenario. So thank you very much for watching, and it's lovely to be back. Really enjoyed giving another webinar, and we'll see you soon. Okay, take care.